My name is Jorge Kaufman, and I'm a research associate in the Department of Family Medicine at Oregon Health and Science University. John Heinzman and I have been invited to share with you our study recently published in Annals of Family Medicine. The study examined acute care utilization for childhood asthma and is part of a larger study of pediatric asthma care quality, for which we have examined prevalence, problem list documentation, and prescribing practices, comparing children in different racial and ethnic groups. So this study took place in a population of community health centers. These centers, CHCs, see disproportionately greater numbers of low income and uninsured individuals and racial and ethnic minority groups compared to national statistics. CHC populations also exhibit higher disease prevalence, making them an important setting in which to study minority health and health disparities. To give a few examples, 63% of CHC patients are of a racial or ethnic minority group compared to 40% nationally. 82% of CHC patients are uninsured or publicly insured. And the prevalence of asthma among CHC goers is around 21% compared to 14% nationally. There's a large population of children receiving asthma care at CHCs in the US. And while there's evidence demonstrating that those who enter CHCs for health services receive equitable care, care utilization may differ across race and ethnicity, potentially leading to poorer health outcomes in some groups. So despite the uncurable nature of asthma, improvements have been made in its management, yet exacerbations of the disease remain common in pediatric populations, according to the CDC. Acute asthma attacks may be managed by the patient, but also increase a child's risk of needing to seek emergency treatment, presumably at a location that best meets the needs of their or their family's present situation. The literature suggests that racial and ethnic differences exist in asthma-related visits, including for emergency department and inpatient admissions, and that typically worse outcomes are observed among children as compared to adults, Black and Latino populations, and Medicaid recipients. So we set out to examine acute care utilization patterns across different settings and different racial ethnic groups among children who receive primary care at CHCs. Specifically, to compare Latino, non-Hispanic Black, and non-Hispanic white children with asthma, we employed a retrospective cohort design on a large multi-state sample of CHC users and a smaller subsample of Oregon Medicaid recipients. We were limited to the state of Oregon for Medicaid claims data. However, the patients in this subset were also part of the larger CHC population. Our study sample was obtained from the Advanced Clinical Research Network, ultimately from 345 clinics linked by a common EPIC-based EHR across 18 states in the US. The children in our study had at least one ambulatory visit as early as 2012, a diagnosis of asthma at age 3 or older, and had a minimum 1 year of observation time to account for seasonal variations in asthma exacerbations. All told, for the observation period of 2012 to 2018, there were roughly 41,000 children in the full CHC sample and 6,500 in the Oregon subsample. So our main independent variable differentiated children identifying as white and non-Hispanic, Latino with preference for the English language, Latino with preference for the Spanish language, or identifying as non-Hispanic and reporting Black race. We measured counts of ICD-coded asthma exacerbation in the EHR and in claims data, as well as sociodemographic, health status, documented care, and overall CHC utilization data. We then reported our findings separately for CHCs in hospital-based settings, comparing the racial and ethnic minority groups to the non-Hispanic white group. So in line with the fact that CHCs serve a large safety net population, the majority in our sample received some type of public health insurance and were always below 138% of the federal poverty level. Despite these similarities, certain cohort variations stood out in our sample. So first, the non-Hispanic white children were more likely to ever have private insurance and less likely to fall below 138% of the FPL. The Latino children in general were more likely to be overweight and to never be exposed to tobacco smoke, while the Spanish-preferring Latino children specifically were more likely to have 3 or more annual CHC visits, to have documented inhaled corticosteroid prescriptions, and to receive both pneumococcal and influenza vaccinations. 3 characteristics we later highlight to help interpret our findings. Lastly, the non-Hispanic Black children in this sample were more likely to receive care at CHCs in metropolitan areas and more likely to have less than 2 annual visits at a CHC. And this distinction is important because standards of care for children with asthma suggest a minimum of 2 chronic care visits per year to best manage the condition. So all of these cohort-specific differences were observed in the full and Oregon Medicaid subsamples. And additionally, specific to the Oregon sample, highlighted in pink, more non-Hispanic Black children were found to be always below 138% of the federal poverty level. In this case, 73% compared to around 56% in the other cohorts. So let's see the results. First, we estimated the odds of ever having an asthma exacerbation visit at a CHC among the full sample of 41,000 children. On the y-axis, you see designations for unadjusted and adjusted results. And on the x-axis are the comparisons to our reference group, non-Hispanic white children, represented by the vertical dotted line at 1.0. The circles represent odds ratio point estimates, and the horizontal lines 95% confidence intervals. A star around a point estimate signifies statistical significance at the 0.05 level. With unadjusted modeling, you can see the non-Hispanic Black and both Latino groups had higher odds of ever having an acute visit compared to non-Hispanic white group, the largest difference observed for Spanish-speaking Latino children. After adjusting for potential confounders, you see only the Spanish-preferring Latino group continued to have disparately higher odds of having an acute care visit for asthma within CHCs compared to the referent group. Next, we repeated these CHC comparisons among the 6,500 children in the Oregon Medicaid subsample alone, reporting again estimates both prior to and after adjusting. Unadjusted this time, we only observed disparately higher odds among Spanish-preferring Latino children, a finding that remains statistically significant after confounder adjusting. So in both the full 18-state sample and the Oregon-only sample, Spanish-preferring Latino children were more likely to have an acute CHC visit for asthma compared to non-Hispanic white children. Now, shifting sites and continuing with our Oregon Medicaid subsample, we then estimated odds and rates of asthma-related emergency department visits. Depicted here, you see the odds of ever having an ED visit with coded asthma exacerbation were disparately higher for the non-Hispanic Black children compared to the white children, with adjusted odds remaining essentially unchanged from unadjusted estimates. For this group, these higher odds were accompanied by higher adjusted yearly rates of ED visits too, though those results are not shown here. And we did not observe differences for either of the Latino groups compared to non-Hispanic white kids in either of the odds or rates of acute asthma ED use. And lastly, among the Oregon Medicaid sample, we examined asthma-related inpatient admissions. The odds and rates for these encounters were similar for all groups, both before and after confounder adjusting. For the patient's observation period, the overall probability of ever having an inpatient admission related to asthma was less than 5%. So there were notable patterns of care utilization in this look at acute care use within CHCs and within hospital-based settings. The group most likely to have an acute asthma visit at a CHC was the group with the highest overall rates of general CHC use for all types of care, while the group most likely to have an asthma-related ED visit was the group with the lowest overall rates of general CHC use. Intuitively, the prior pattern is preferred to the latter, seeing as those who were high overall CHC utilizers also were more likely to receive important preventive care like inhaled corticosteroid prescriptions and respiratory infection vaccines. And since ED visits for asthma often occur for preventable crises, and a common, if not the most common cause of exacerbation is acute respiratory infection, the higher CHC use may help keep children out of the ED for their asthma care. So why the difference in utilization patterns? We know that CHCs provide high quality care, often achieving better outcomes in disease control and health policy goals than national averages. Their patients are getting good preventive care education and are really satisfied with appointment time availability and their overall care. And more research are suggesting that minority health and health disparities are better in CHC users compared to US population at large, but perhaps not equally for all groups. This high quality care that CHCs are providing is to a large volume of individuals and families with low income and those lacking health insurance or the ability to pay for services. So the different patterns of utilization, which we observed, suggest factors beyond affordability may influence the accessing of care. In our paper, we discuss some of these possible factors supported by the current literature. We point to racial and ethnic specific influencers for both increased and decreased seeking of chronic care. And we also expand on the downstream effects of poverty and recall its greater distribution among non-Hispanic Black children in our study compared to the other children. Understanding these many influencers and the social constructs that frame and either mitigate or perpetuate disadvantage in the seeking and receipt of healthcare is crucial to the goal of reducing disparate health outcomes and for improving the health and well-being of everyone in this country. So this slide here summarizes our study findings, and I'm going to pause here to open it up for any questions or comments.
Great. Well, while we're waiting for questions to trickle in, please do submit them if you have them. Maybe you could speak to, now that you have observed these patterns, what maybe family medicine practitioners or people that are involved in working at CHCs can take away from this and then use to change the ways that they're delivering services?
One thing I think would be to try to understand what is contributing. So potentially qualitative assessments on what are the barriers for patients coming in to receive, the minimum recommendation of chronic care and preventive care visits. What are the things outside of having this affordable care available are getting in the way?
Yeah, I have a couple of thoughts too. I agree with that. I think it's a call, and me as a practicing family physician myself, even in a community health center. I think this would lead to a little bit more, as a first step, awareness of the ways in which we deliver care, especially in a community health center setting. But there's lots of family physician offices that deliver care in a very similar way. That even when we do that effectively to patients with barriers, that really the study highlights that barriers are very different between groups, and that obviously we kind of all know that, but the study really highlights that in very practical ways. And so understanding that your African American children with asthma may not, in some ways the system that we practice in might facilitate Latino children getting in when they have an asthma exacerbation, and African American children not as readily, and kind of the system shunts them to the emergency department for whatever reason. Being aware of that dynamic is kind of a first step, and obviously this is a macro dynamic, but trying to see if that would apply to your situation, and create processes and workflows that would get kids in for exacerbations in the community health center whenever they can. So obviously it'll be a community by community issue, but number one, understanding the differences in how groups might access care, especially acute care or exacerbations in a chronic disease, and then trying to create systems, workflows, education that would that would address that and get people in for acute care when they need it. I think that those are two of the big take home general principles from the work. I don't know, Jorge, does that resonate?
Yeah, and the other thing I think I would add is that there's increased efforts now to collect social determinants of health information, risk factors, and I think along the same lines, what we're observing highlights the need to do this. Is transportation an issue that needs supporting? What are the other things beyond the affordability of a service that are preventing its utilization, and that social risk screening, I think, is an important aspect to integrate into clinics.
I think the other thing that, and this is a little bit more at the level of, it would be for the doc and the provider, but also at the kind of the level of the medical director, the health system is, one of the things that the study really points out is, there are obviously barriers and disparities we saw, but there's this hint of, especially in some of the Spanish preferring Latino children, of good access, or citizens of good access, of access that is at times what it should be, or is not disadvantaged, that the access to the community health center in the setting of an asthma exacerbation is present, which is good. And I think we often don't understand or study or promote the idea that, actually this is the system might be performing here. And so the question is, why does it perform in this high, kind of more highly in this group? Or what about that group? Not just to take the credit for the system, but what about the group? What are the strengths of the group that are able to kind of access the system appropriately in that setting? And so essentially understand the positives there and leverage that to grow and improve more globally. And honestly, I'm not sure we understand that yet fully. I think Jorge mentioned, we've seen that in other disease areas, that the Spanish preferring Latino patients are often utilized more and high and appropriately. And so why, and what is that, and what can we learn from that in order to better the care for everybody? So that's a little more of a macro lesson, but I think it's one that would resonate with the doc in the clinic as you think about your clinic day, your panel, who might be utilized, who might not be.
Definitely. We have a comment. She brings up a good point too that kind of speaks to that macro analysis of that it's difficult to figure out what factors race and ethnicity truly represent when you're doing a quantitative analysis of any sort. So maybe you could speak a little bit about that. It's certainly a hot topic in the research world.
Yeah, definitely a good point. And this is, as John mentioned, one piece of the understanding. And our objective observation, our quantitative analysis, it provides it just provides more reason to do qualitative studies, I think, and to really engage with communities. And at that point, it's the qualitative components may not be, they may not have to be separated into these socially constructed racial and ethnic groups, right? And as John said, just understanding what works for people and trying to, improve the pathways for everyone.
Yeah, it's a good point, Lily. And I think, obviously we use with what race and ethnicity represent, we use just kind of self-identified categories that people say to the CHCs, and that's it still doesn't necessarily that's not always helpful. However, I think that to further your point, actually, Lily, the idea of teasing out by language specifically for all the limitations of certain ethnic, racial, and ethnic categories, that at least is in some ways more practical. It's a little more of a real world I don't want to say less open to interpretation because that's not entirely correct, but it is a little bit more of a real world measure of a person's kind of culture or possible barriers or and so anyway we feel that's a strength of the analysis just because we're able to look at that very practical feature, which in some ways gets grounds, I think, these ethnic categories in a little more of the real world.
Sure, and I'll also add too, we had an interesting paper published recently on an attempt to contextualize and come up with a way to measure race and the things, I'm doing a bad job of summarizing it, but a way to look at the underlying systematic structures and infrastructures that influence some of these disparities in health. I'm going to paste a link to that in the chat for those that are interested. But before we close, we had one more question, a little bit more directly related to your paper on, maybe you can speak to whether your research or other literature points to alternatives to CHCs for acute asthma care for underserved populations, or perhaps also you could speak to any potential areas for improvement on that metric as well.
I think we kind of consistent with what one of the last context slides that Jorge showed, the idea that generally, I think the research is pointing towards that community health centers would kind of be better at providing some of this access than other systems because of the way, the implication because of the way they're set up. That's an assumption. I think, but I think the reason, and this is a little bit of my extrapolation, is that generally community health centers are embedded in communities, have some features that are tailored to communities, and there are practices all over our country that have some of those features even when they're not community health centers. I know many here in Oregon, especially rural practices that may or may not be community health centers, but embody some of those values, community orientation, and may be able to provide that access in ways that other practices can't or don't. So I think that's just one, to focus on this, not necessarily the community health center title, but the way of delivering care, I think would be the lesson. And for reading the second part of the question. Second part of the question?
Second part, they were asking for kind of your thoughts on any potential areas for improvement on some of the metrics that you used.
Oh, I think there's lots of opportunities for improvement. I think, as always, we strive to, there are lots of initiatives to better chronic disease care overall. I think what this highlights is specifically in this issue of access to acute care, and whether people, when they pay, these patients, especially the non-Hispanic Black patients, or if they're able to get into the community health center or any clinic when they are sick, is really the opportunity for improvement. That's the metric overall. I think the underlined take-home exclamation point metric. That's what I think where the needle would need to change, and the opportunity for improvement highlighted by this study.
Yeah, the only thing I can think to add is as far as like alternatives, this was a look at utilization for acute exacerbations, and obviously we would like to prevent acute exacerbations as much as possible, and one of the things that it seems from our observations is that greater utilization on the chronic care side of things is potentially a benefit. So as far as like an alternative, I know that if for example there are transportation barriers to getting to CHCs, I know that there are mobile sites that can also be useful in delivering the chronic care, the preventive stuff, the stuff that happens before the acute care utilization that we were measuring.
Great. And before we close out, we did have one of our guests was wondering if the trends that you saw, particularly for Spanish preferring Latino patients, if that was linked at all to patterns related to the Hispanic paradox. And if you had any insights for future research in that area.
I thought about that, Jorge. Do you have a thought?
You do have a thought?
I do.
No, yeah, go for it.
So it's an interesting point. So I think the Hispanic paradox, and it's probably immigrant paradox, both terms are used, really speaks specifically to a mortality advantage witnessed in immigrant population, especially Mexican immigrant folks, but it's been kind of generalized to Hispanic folks in general, sometimes appropriately, sometimes not. It looks basically at the mortality advantage despite usually socioeconomic disadvantage. I think we are learning a lot about what happens, a large portion of our Spanish preferring Latino patients will be either recent immigrants, immigrants in general, some of them first generation Latino Americans, there's a lot we don't know, because that mortality advantage goes away as people spend time and generations in the United States, and no one really knows completely why. There's lots of theories and there's some evidence, and so this is where that has not been extended to is health service utilization, and so studies like this hopefully in the future will kind of help define essentially what happens to those generations who immigrate and then live in the US, what happens to that mortality advantage and why, it's kind of an intermediate outcome, or do people actually use more services, and why is that? Are they sicker? Who knows? But it is a piece of that question. It's not necessarily related directly to the paradox, because that deals with mortality, but it's part of us trying to understand exactly what happens to that population as they spend time in the US. So it's a great question. Thanks.
Well, with that, we are at time. So thank you all for joining us today. And with that, we are signing off.